Hi, my name is Nikhil Hooperkar, and today we're going to talk about ARDS. So Jess, what do you know about ARDS?
I know there's a bunch of things that can cause it, like sepsis or trauma, lots of things that can cause it. Pancreatitis, people think of a lot. But I always think of it if I have a patient who is hypoxic and has like bilateral fluffy ugliness on their chest x-ray.
Yeah, so when we talk about ARDS, what we're talking about is a version of an inflammatory hypoxia, okay?
Okay.
The way we go about diagnosing it is we're going to look for a P to F ratio. So when we do an arterial blood gas, get the oxygen, the partial pressure of oxygen there, compare it to the FiO2, so the inhaled, the fractional inhaled oxygen, and from that we get a ratio. And so normal is about 500, okay? And then we start grading it as abnormal from 300. And as you get closer and closer to zero, we get more severe. So mild is from 300 to 200, moderate from 200 to 100, severe is less than 100, okay? So the big criteria, so that we're all talking about the same kind of thing for an inflammatory process of the lungs, is it has to have occurred 1 week, the initial insult, the initial hypoxia that we're talking about, occurs within 1 week of the initial insult. You have a bilateral fluffy infiltrates on your chest x-ray. It has to be present when you have a PEEP of greater than 5. So ideally pushing out a little bit of the water that would be there. And then the last part is it can't be cardiogenic.
What are the ways that I can make sure someone has a PEEP of 5?
So most of the time we talk about a PEEP greater than 5, we're talking about a patient being intubated and on mechanical ventilation with a PEEP greater than 5 that way. We don't really know the exact PEEP that's present in the central airways when you put things such as the BiPAP mask or CPAP on. So we should really be talking about this when you have these fluffy infiltrates and you're intubated and in that setting with a PEEP greater than 5.
Okay.
Does that make sense?
Mm-hmm.
So when we come up with a diagnosis of ARDS, it really boils down to two major portions of our therapies. There's the ventilator portion of our therapy, and then the medical portion of our therapy. And so for the ventilator portion of our therapy, what we're talking about, what we're looking for is low tidal volume ventilation. And so what that means is we target something at 6 milliliters per kilogram of ideal body weight, and we can change that range a little bit to 4 to 8 to try to optimize the oxygenation, but also kind of balance with the plateau pressures. And we'll talk about that in a second here. So we have a couple of goals, things that we're trying to do to kind of optimize the ventilation that you get, optimize the oxygenation, and really minimize the long-term bad effects from opening and closing the lungs a lot. And so those are keeping a PaO2 of greater than 65, which corresponds to having a SAT of greater than 88%. We want a plateau pressure of less than 30 centimeters of water. And we want a pH that is greater than about 7.15 to 7.2. I put 7.2 just kind of for simplicity there. And try and keep a respiratory rate less than 35 is kind of what is the most standard. And so that package right there is kind of what we call low tidal volume ventilation. When we get those settings and when we start titrating, right, to either titrate up or titrate down, we titrate based on what's called the ARDSNet protocol, which is a list and it has a table for both high and low PEEP, where you can kind of see what FiO2, what PEEP you should be at, and then bring them down in kind of a systematic fashion, or if you're not reaching your oxygenation goals, increase them in also a systematic fashion.
Okay.
Does that make sense?
Mm-hmm.
All right. So as far as medical therapies for kind of optimizing our outcomes in ARDS, big things are getting the patient to pee. We want dry lungs or happy lungs, and so the more fluid that we can get off of the entire body, the better off we think our ARDS outcomes are going to be. Other things are if we're still not managing to get good oxygenation, if we're barely getting our PaO2 of greater than 65, we can talk about paralyzing patients, and if that fails, we can talk about proning patients. And these two, we really start talking about them or incorporating them when that P to F ratio goes under 150, okay? The last thing in the medical therapies is prednisone. And I put prednisone up there mostly because it started with a P, but methylpred would probably be the way to go in terms of steroids or IV steroids. The idea being here that if there's an inflammatory component to the ARDS, that we could maybe decrease that inflammatory component and potentially help the lungs heal faster. Now, just so you know, this prednisone or using steroids in ARDS is at least slightly controversial. The current COVID guidelines suggest using steroids, but just realize that this might be subject to kind of change in the coming days or coming weeks in terms of what the best therapy is. As far as salvage things that we can offer if we're still failing to get good oxygenation, because that's really where our ARDS patients kind of have the most trouble, is maintaining good oxygenation. We can talk about using inhaled prostacyclins. I have inhaled nitric oxide because that's something that we can offer, but it's not currently recommended in the most recent SACM guidelines. APRV is another thing that we can offer as an attempt to get better oxygenation.
What's APRV?
So APRV is a vent setting where you establish a high level and a low level, set time frames, ideally spending more time at the high pressure and the low pressure, but basically this is
so it's a complicated vent setting.
Complicated vent setting.
Okay.
And then ECMO being the last option.
And what's ECMO?
So ECMO is extracorporeal membrane oxygenation, and so it's basically a dialysis version of ventilation and oxygenation.
Okay.
So with that, that's kind of the quick rundown of ARDS.
So can you remind me again how I get that P to F ratio?
So that's based on an arterial blood gas. So looking at the partial pressure of oxygen in an arterial blood gas and comparing that to the fraction of the FiO2 that you're breathing in. And so normal FiO2 on room air is about 21. And so the fraction of inhaled oxygen is normally present on all of the ventilators.
Okay.
And how do I find a plateau pressure?
So plateau pressure is a maneuver that you can either do by yourself or you can have the RTs do for you as the end of an inspiratory hold. And it's supposed to represent the pressure that is out there in the periphery of the lung or in the alveoli.
And one more question. So can you explain to me again, like the PEEP? So how high can I go on my PEEP?
So the PEEP settings are intended to, so the highest PEEP setting is approximately 16 on the ARDS tables. You can, normally we start our PEEP settings at around 10 and titrate up or down from there, especially in these ARDS type patients.
Okay, so as long as I keep that plateau pressure less than 30?
Less than 30.
Okay.